Good afternoon, everyone. First of all, I take this opportunity to thanks Dr. Muthu, Dr. Kritika, the management of Sri Ramachandra Dental College for inviting me to speak on this podium of SECRE 2.0. My topic today is resin infiltration in early childhood caries. I have tried to summarize my presentation with using the following outline. Initially, I will try to summarize the stages of early childhood caries, followed by what is resin infiltration and how it is used in early caries or the white spot lesion which are due to caries. Then I will shift my focus specifically on primary teeth that includes early childhood caries and how it is used in facial and proximal lesions. Then something about the literature and the published evidence about this thing. So starting with the summarization of early childhood caries. Life of a pediatric dentist or any general dentist revolves around only three things. Initially, it revolves around saving the healthy tooth in the same state, then management of the carious lesions or management of the infections because of untreated carious lesions. Now, conventionally or historically, what we do is that we tend to restore these carious teeth using some surgical management and by making cavities. So this approach always wants us to detect the carious lesions at the cavitation stages. However, if we talk about the contemporary perspective, the carious tooth is not only involves the cavitated lesion, but it also involves the non-cavitated initial carious lesions. And as a pediatric dentist or as a dentist, it is our duty to save or to arrest the lesions at these stages so that these early lesions do not progress into cavitations. So broadly, if we say there are two types of lesions, non-cavitated and cavitated lesions, no doubt we have a broad ICDS classification of caries, which helps us to record each and every stage of caries. And for these non-cavitated lesions, we have to do something non-operative care, and only for the cavitated lesions, we can use surgical care, which involves making a cavity, but that should also be using some minimal invasive dentistry approaches. For pulpal infections, we can go with the PUFA classification and then treat them accordingly. Now, specifically for the early childhood caries, it is also described as initial deep caries, severe or damaged and traumatic lesions depending upon the depth of the carious lesions or the how much tooth portion has been already destroyed because of the early childhood caries. Now, for these initial caries, non-cavitated lesions, we have either lesion remineralization approaches or arrest approaches, and only for the cavitated lesions, we should restore and rehabilitate for function and aesthetics. One recent classification that also describes the early childhood caries involves ECC score 0, which is sound, ECC score 1, then 2, and then 3. Now, specifically, we are going to talk about these smooth white spot lesions, maybe on the proximal zones or maybe on the facial zones, that involves the management using resin infiltration. Now, what is resin infiltration? Now, we know that the lesion may start as early and we can use sealants or remineralization strategies to prevent the progression of such lesions. And then there are surgical approaches for permanent as well as primary teeth when we see that the lesion is already cavitated. Now, between these two non-invasive and invasive approaches, there is a novel approach which is micro-invasive in nature, and that is called as resin infiltration. Resin infiltration is a term which is used synonymously to the caries infiltration because it involves infiltrating the caries using low viscosity monomers of resin. And it is done with the help of a commercial product which is called as Icon. And this Icon name is derived from infiltration concept. So the principle of this is simply that the low viscosity infiltrant can percolate into the outermost surface of the early non-cavitated carious lesion because of the porosities, because of the capillary action, it enters into the lesion. Now the armamentarium is very simple. It has three syringes available. The first syringe is etchant. This is called as Icon H. Second is the icon dry, which involves pure ethanol. And third is the infiltrant. Now, this infiltrant is the low viscosity, or I would say very, very, very low viscosity monomers. And this icon H is nothing but the hydrochloric acid, that is 15%. And this icon alcohol, that is the second syringe, is the pure alcohol or ethanol. Now, the kits are different for the icon which is used in proximal lesions and the icon which is used in the vestibular lesions. The basic syringes remain the same. So the first syringe in both the kits will be etchant, the second will be icon dry, the third will be icon infiltrant. The main difference is in the applicator tips. For the facial lesions, the applicator tip is of concave surface so that it is able to attach to the convex surface of the primary incisors. And while on the proximal surfaces, it is like a mylar strip, and this mylar strip can enter between the proximal contacts of the two teeth, and the material can be pushed from this. And this particular mylar strip is kind of a giant trouser pocket, and from the pocket there are holes on one side, and from those holes the material can come out and get in touch with the proximal surface early carious lesion. Now the steps involves etching, that is using the icon H with 15% hydrochloric acid for 2 minutes. The second is that after washing it, you have to dry with icon dry, that is ethanol, for 30 seconds. This is followed by accentuation. This accentuates the microporosities, which are now ready to take the low viscosity infiltrant, and then we infiltrate the lesion using very low viscosity infiltrant, which is also supplied as the third syringe in the kit, initially for 3 minutes, followed by a light curing, then again for 1 minute application, again followed by light curing. So these are the 3 steps which are done whenever we do resin infiltration for primary or permanent teeth. We can definitely customize the application of acid etchant depending upon the depth of the lesion, specifically in the developmental porosities or developmental white spot lesions, or fluorosis lesions, or MIH lesions. But specifically when we talk of early childhood caries, this particular protocol is perfectly okay, and you can just go for 2 minutes of icon etching. Now, as I explained you, the principle of resin infiltration is that this infiltrant peeps into the lesion, into the porous lesion. This infiltrant now fills the lesion. This sealed lesion, which is filled by this infiltrant, acts as a barrier to acids and fermentable carbohydrates. Now, the infiltrated artificial lesions do not progress in the choriogenic environment. So the lesions which wanted to progress, but because now they are sealed because of this infiltrant, will not progress. So the principle of resin infiltration is simple, that the infiltrant seals the inner lesion or seals those microcavities, and any of the acid or any of the acid byproducts which are being produced in the oral cavity are not able to demineralize the tooth any further. So the indications, specifically indications for white spot lesions, are proximal lesions, post-orthodontic, poor oral hygiene, fluorosis stains, and any other kind of white opacities. Now, this is in general. We have to shift now. Now, we have already discussed the principle of resin infiltration. We have discussed the clinical technique of resin infiltration. We have just taken an overview of what are the indications. We have to now shift towards primary lesions. But before that, we should understand that in addition to stopping the caries progression, this resin infiltration also leads to aesthetic improvement in the facial zones. This is because of the similarity of the refractive index of the sound enamel and the infiltrant, that is 1.52 is quite closer to the refractive index of the sound enamel. So that's why we are able to see immediate improvement in the aesthetics when we use resin infiltration in the proximal lesions, in the facial lesions. Specifically, when we talk of the proximal lesions, we should understand this decision tree. Now, the proximal lesions, if we say, these proximal lesions are usually detected using the IOPA or the bite wing X-rays, and this is a radiographic classification as per the progression of caries. Now, these are the even lesions. These are the E2 lesions, simply because this lesion is in the outer zone of enamel. This lesion is in the inner zone of enamel. This is the D1 lesion. This is the D2 and D3 lesion. Now, the research has shown, or the observational studies have shown very clearly that E1 lesions and E2 lesions are usually not cavitated. D1 lesions are also only 50% cavitated, and D2 or D3 lesions are probably cavitated. Now, these are the lesions which which we should treat using invasive approaches. E1 lesions will be treated using non-invasive approaches like fluorides, improvement in the oral hygiene, etc. Now, E2 and D1 lesions, in spite of going for any invasive approach, we should check for the cavitation stages or the cavitation status. If they are non-cavitated, then these are the indicated lesions for resin infiltrations. So both E2 lesion and the D1 lesion, that means even in the deep outer zones of dentine or deeper zones of enamel, these are the lesions. If non-cavitated, treat them using resin infiltration in a micro-invasive manner. So this is the decision tree. Now coming to the resin infiltration in the primary teeth, resin infiltration can be very safely used for primary teeth, both for the facial and the proximal lesion. Now, this is the clinical case which clearly shows white spot lesion which would convert into some cavitation if we do not do something over here. Now, if we want something in a one sitting approach, also to improve aesthetics, micro-invasive approach, then we can use resin infiltration very safely. And this resin infiltration improves the aesthetics, stops the caries progression within one sitting, within 15 minutes, and you will be able to achieve this particular results. Now, when we see such kind of lesions, which are E2 or D1 lesions, maybe on one side, or that is the one tooth on the proximal side, or adjoining lesions. Now, these are the lesions for which we should check the cavitation status, which can be done using the dental floss or separators. And only if you find a clear-cut sign of cavitation, you can use some invasive approach. Otherwise, these are the lesions which should be treated with the resin infiltration micro-invasive approaches. Now, the steps for the resin infiltration in the proximal surface would be, after doing the rubber dam application, the first step would be icon H. As I told you earlier, this is to be done for 2 minutes. This will etch the surface, wash, dry, and then dry with the ethanol. This ethanol will enter into the pores which are accentuated by icon H. Now, when it goes into the pores, because of the desiccation of the or the volatility of the icon H, that is the pure ethanol, because of that volatilization, the ethanol will wash off and it will leave a very dry surface, which will be ready to take the infiltrant. Now, the third step will be 3 minutes of application of infiltrant, which is nothing but a low viscosity resin, followed by light cure, and then 1 additional minute of icon infiltrant, followed by the last step of 1 minute of icon infiltrant. So now coming to the literature and evidence. Now, it's important that we should understand that if it is working, do we have sufficient evidence it works before actually taking into clinical practice? So this is one of the narrative reviews which was published few years back, and it is resin infiltration in proximal lesions of primary teeth. Do we have enough evidence for recommendation? I have tried to summarize this narrative review in 5 questions: that is it working? Is it safe? Is it acceptable to dentists? And do the systematic review proves the evidence? Using these questions, I have tried to conclude that we do have evidence favoring the microinvasive resin infiltration procedure in the management of non-cavitated proximal lesions in the primary molars. So I have tried, this is a kind of a narrative review come umbrella reviews. I have tried to summarize all the systematic reviews and find this conclusion. In addition to this, I also want to highlight one of the Cochrane reviews, which has summarized the microinvasive interventions for both proximal decay in both primary and permanent teeth, which clearly the forest plot is clearly indicative that it is favoring the resin infiltration when it is comparing it with the control, or resin infiltration when compared with a placebo control. So this is, and even when we are using something called as digital subtraction radiography, for when the progression is 12 to 18 months, even then the results using the forest plots are in very much favor of resin infiltration. So even the Cochrane review, we can see that it is in favor of resin infiltration as compared to control or placebo control, which includes proximal sealants or proximal varnishes. So all the strategies which are used, which are conventionally used to arrest the lesion in the proximal zones compared to the resin infiltration, shows that resin infiltration favors or is significantly better as compared to other approaches. I also want to show you one recently published network meta-analysis which has compared resin infiltration with fluoride varnish, with toothbrush flossing, and with sealing. Now, this table clearly shows that the odds ratio of the resin infiltration compared to fluoride varnish, compared to toothbrushing or flossing, and compared to sealing is all favoring resin infiltration. At some points, the results are imprecise because the confidence interval is quite wide, but all the results are still favoring the resin infiltration as compared to other strategies. So this is the table of comparing of treatments for non-progression of caries lesions in the proximal surfaces. Now I want you to read this line. Analyzing the management options for proximal surfaces, 6 studies included in the network meta-analysis showed that resin infiltration presents the highest probability to avoid the progression of initial caries lesions, probably because of the ability of light cure resin to penetrate into subsurface enamel lesions and therefore sealing and etc. So this is very clear that it is the RI, that is this novel micro-invasive approach using ICON, presents the highest probability to avoid the progression of initial caries lesion. So even the recent published network and meta-analysis, which is the culmination of all the published studies, also show this thing. So this is another uh, table from the same thing, which also shows, which favors for the that for the buccal and the lingual surfaces, the resin infiltration is also better. So this table was for the proximal surfaces, and this table depicts for the buccal and the proximal lingual surfaces, that is the facial zones, and this table is for the occlusal surfaces. For that means for all the different kind of surfaces in the primary teeth. So this network meta-analysis was specifically only for the primary teeth. So for all the surfaces, it is very clear that resin infiltration presents the highest probability to avoid the progression of initial caries lesions towards the cavitation stages. So if we have such a fantastic approach with us that allows us to treat the teeth in a single sitting, to arrest the caries in a single sitting, also provide good aesthetics, I must say that you all should promise to yourself that this should not be the end in the mind, but it must be the beginning of the micro-invasive era or micro-invasive approaches in your minds. With these words, I thanks everyone for the patient listening, and any questions, I'm ready over there. Thank you so much.